we have one last section to go over, and that section is sitting right here. We're in cost and use. We haven't touched some of these top ones here, but we did do radiology already. We're going to go into pharmacy now, and we're going to look at pharmacy population. So I'm going to click on pharmacy population, and once again, the same kind of stuff pops up in terms of dimensions and in terms of measures. But again, you're going to notice that all of these dimensions and all of these measures are now very specific to pharmacy, just as they were specific before to the radiology. In this case here, as you work your way down, you got pharmacy qualified status. That's a pretty important one right here. If you don't include this, you're going to get both. Prescribing provider, prescription date, type of service to the NDC code. This drops it all the way down to the lowest possible level. And then when you look at your measures in here, we're looking at measures that are specific to pharmacy. We'll look at, number of scripts per thousand, generic prescribing rate, brand prescribing rate. So if we take this and we want to kind of split this up and we want to say, okay, how do we want to look at this? Well, your custom fields up there are probably a great way to look at that, or perhaps product is a good way to look at that. So let's just pick one, and I'll pick product.
I have a question.
Sure, shoot.
Is there prescriptions per thousand normalized in a way where 30-day prescriptions are counted differently than 90-day prescriptions?
That is absolutely correct. So we take them and we all make them on the same basis, if we know it. I'll be honest with you, if we know it. So if it's coming through as a 90-day supply of something and you got it mail order, that's taken into account. But if it's 90 days every if it's ordered on a monthly basis but you get 90 of them, that becomes monthly.
Okay.
So basically what we do is we take all the pharmacy scripts that are mail order, that are typically for 90 days, and we convert them back to monthly, and then we go forward.
All right, thank you.
Okay, so let's say we do prescriptions per thousand into the data area, and we're going to do product, and we're going to add that to a row axis. So now we've got your Medicaid, Medicare, and commercial, and you can see that the Federal Employees Program, FEP, has the highest rate of prescriptions per thousand. Is that surprising, Sarah? Nope. Now, we may want to say, okay, well, let's investigate this one a little bit more carefully. We can actually go down to products levels 2 and 3 here, and in this case here, it's basically HMO. Well, what's going on here? What's going on with the 15,000 that's twice as high as the commercial product? We might want to investigate what they're taking. So in this case here, what I might want to do is I might want to take this product level, and I might want to take that product level and move that dimension to a filter. And then I might want to just say, I'm going to focus in on just the FEP program. So only that program there. Then I might be going out here saying, okay, well, let's take a look at those particular prescriptions and let's look at them by type of service. And I'm going to drop the type of service into a row axis. And here's where we get to their highest level of pharmacy, and I want to see which is the best or the most used drug here. So I'm going to sort it descending. And we have unknown and undefined. And then we have skin, we have respiratory agents. There we go. Central nervous system agents. I didn't sort that right. I was wondering why the numbers didn't look right. Okay, so this particular program, the Federal Employees Program, uses central nervous system agents at the top of the list. That's got to be different than the commercial.
So that's a super small set of patients.
Aha, so Sarah's informed me that's a super small set of patients. So we probably shouldn't be looking at that.
Correct.
Okay. See, I didn't know your population that well. When I saw federal employees, I figured, oh my God, there's 1,000 of them. There's thousands. All right, so we'll actually change that.
I wish that weren't even
A category? Okay, so what we'll do is we'll go and we'll just look at the commercial ones instead. I thought I remembered WBA. They were a huge chunk of WBA, though. WPS, oh, okay. Sorry. And again, it's central nervous system agents for commercial, and if we open that up, we can actually go down to several levels of service, all the way down. In this case here, we're going down once again. And we can see, let's see if I go over to the right a little bit, high prescriptions for whatever sertraline is. And if we go to the next level, it should be the NDC level. And there should be a bunch of NDC codes in there. And I'm sure you guys that are clinical, you know these terms already, so you actually already know what those drugs are. But you can actually drive it down to the lowest level. Now, if you wanted to compare two of these next to each other, let's say I put up there commercial, and you want to compare commercial to Medicaid in the exact same space, you could actually put, instead of just scripts per thousand or the NDC number here, you could put them side by side. So let's take it from the filter now and drop it down, but looking at just that agent. So we're kind of flipping it on its head, if you will. So instead of having commercial here, what I'm going to do is I'm going to take that and I'm going to move that dimension to a column. And so now we have the commercial, we have the federal, the Medicaid, and the Medicare. And even at the column level, if I don't want to see the federal in there, I can actually select this here at this level, set the filter at this level, get rid of everything but say commercial and Medicaid, say OK, and all we're going to have left are those two. There we go. So now we're comparing directly these two. And if I start opening this up to type of service level 2, you're going to see the comparison between commercial and Medicaid in this space. Serotonin inhibitors are higher. This one's almost double. The narcotics and analgesics. The antidepressants are almost triple. So we're doing a comparison, and as we go down one more level, you'll be able to see some of the generic names. Now another cut on this might be by region. Who's prescribing what to whom in what region? Is the urban region prescribing more of something than the non-urban region? Okay, so now you can see for the oxys, the hydros, and all of those codones, all those narcotics, if we move to the right, you can see that we've got a lot more being spent over in the Medicaid space than over in the commercial space. So that's the way we kind of look at this. Then the other way to look at this,
Are these prescriptions per 1,000 again?
correct.
So how come there's no number that's higher than 269? Oh,
We're at a very, very low level here. That's 377 scripts per 1,000 people.
no, I guess I'm thinking, maybe I'm probably totally missing something. But for the narcotic one, the one that you made,
That's the one I'm on right here. Yep, this is this.
shouldn't at least some of them be higher than the total? Or not the total, but then the average when you weight all of them, or when you put them all together?
All right, so I'm going to put them all together. And so 269 per 1,000, right?
So that means some of them you would expect when you expand it, some categories would be more than 269 and some would be less? Since 269 is for the overall category?
Well, these are narcotics, and potentially, or I shouldn't say potentially, generally speaking, they're not given for a full year. So there's a whole lot of give and take in there per 1,000 kind of thing. And we're doing it on a per year basis, so I can't really say. I could go through the math and we could figure it out. But in something that's like, let's pick a different one. Let's pick one that's given for a whole year. Hypertensive? Yep. Let's see, where would I find those? Under cardiovascular? Tick, 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 tick. Okay, which one's a hypertensive? Antihypertensives, right? Any one of those would work?
But for cardiovascular as well, it says that the rate is 1,598
Yep.
per 1,000, but all of the rates for each individual drug are much smaller.
Those all add up to it.
It should.
Oh, so you're saying this one is a sum?
Yeah, because we're
this
drilling
is
down
a-
to each one, and then it sums it.
Before you said it was an average.
Oh, my bad.
Yeah.
No,
But
it's a
actually,
sum.
that didn't even average out. That was-
No, my bad.
So how do you know how? Like, are some of them classified differently then, so that some of them are average and some of them are additive?
Let me think about that for a second.
Why would they be additive if it's per 1,000? I feel like that should be a rate.
I'm going to have to take that one back.
Yeah,
I don't know the answer to that. I'm going to have to take that one back. We will get you an answer on that.
And then the other one that was an average, that wasn't a straight average.
Right.
That was some sort of weighted. So
It was a weighted average,
how was
for
it
sure.
weighted also?
Okay, we can answer that as well. Good questions.
These are all calculated in the same denominator, correct? So it should be the same.
Well,
They should be calculated on the same denominator, but it's not really exactly the same denominator because people enroll and disenroll at various times of the year. Yeah, so I think it would be close enough,
Like if
to be
before it
honest.
said the average was 158 and it's actually 88.
Yeah, but I think it's the same because it's calculated on the same.
All right, so I'm gonna
base
do a
population.
screen print of this.
Denominators and the ones, the numerators should all line up. To what the average is? To the total for the category.
Yeah, I know, but I'm saying in the other one,
No.
Yep.
he said it was an average, but it wasn't averaging what
Right.
what it said the average was.
We'll get you an answer to that. I just took a screen print to remind myself and email myself. So we'll check that. And we'll get the answer back to Sarah, who can then distribute it out. Let's see here. Okay, so the only other dimension that might be interesting here is geography to county dimension, to see if there's a difference in, where it's being done. And if we do the county level and replace the row axis, here's all the counties, and we probably should have gone in there and actually taken the counties and just done the counties in Wisconsin, because some of these counts are very low. So we could set the filter here. I think everybody's doing it because it's taking longer. There we go. So now we have by county, by commercial, by Medicaid, by commercial, and by Medicaid. And you can see there's a different rate. Now, just keep in mind that not only can you filter at one level, but you can filter at multiple levels. So for example, if I only wanted to look at a certain drug or a certain channel, for example, I could take channel and drop this up here in the filter condition. So now I've actually filtered not only the rows, but the columns, and I can actually filter the channel right here as well. So I've got all three things filtered at once. And if the channel here is just mail order, we can select just mail order. So if I wanted to look at just the mail order, I could select that, but remembering that the products are filtered and the towns are filtered. And you can see we have very few in there as mail order. Is that a flag, Sarah? Mail order? It doesn't look like it. Okay. So we'll just do retail. Yeah, you guys don't have a flag set for retail and mail order, so the flag isn't there. That's why we're picking up zeros there. And then last but not least, we've got this cost and use cube. Again, it's either population, episode, or overall admissions. Let's look at the overall admissions for inpatient. The population and the episode cubes are very similar. So in this particular case right here, you've got to have something based on admissions here. And we did something earlier, which is the inpatient readmits. But the thing to remember on any of the cubes, you can't hurt them, number one. You can't mess them up, number two. If you don't like what the answers are, you have to drill down and get to where you want to be. So there's no right answer or wrong way to get at these. You can use multiple cubes to do the same thing and get similar answers. The thing to remember is that when you're looking at these, and you want to get exactly the same answer that you see in the quick lists, the quick lists do a lot of work up front. You need to know what to exclude, what to include, and where to put it. So all of that's really part of what you choose to filter coming up and down here. And the population cube has population statistics. And I know early on, like 1 o'clock this afternoon after lunch, folks were like, whoa, why can't I see all of the stuff that you see in here? Well, that's because you're in the wrong cube. And you just have to get used to which cube you're in. And you can see on this particular cube, it's a population cube, right? Cost and use. It also happens to have both DRGs and ETGs in it. That's something we haven't seen anywhere else in the application. So you can do both in this particular one. You can also look at things like place of service here if you wanted to. So if we took place of service, something we haven't done before, add it to the row column, and then look at, okay, where's all my money going? I'd go into population service, total standard cost, and you can actually see where all your money's going. We can almost guess where that's going to be at the hospital, but let's see what it looks like. Any kind of queries you guys are interested in doing in any of the cubes, in any of the quick lists, I'm happy to try to do them in the next 10 or 15 minutes.
This isn't a query, I guess it's just a general question. The cubes are mostly around cost, right? There isn't any cubes built around exploring quality, right?
That is absolutely correct. There is no quality in the cubes whatsoever. Yep.
And is that, I'm just curious if that's like a structural thing, like it just wouldn't make sense to explore quality through a cube, or?
Well,
is it something-
if you think about it, you could explore quality through a cube. We just didn't choose to do it because quality was a much simpler aspect. Because quality is either, remember, on or off. You're either compliant or you're non-compliant, and here's your set of 484 rules. So you can't really drill into it. The only thing folks have asked in the past is, well, can you show me how that member was compliant? Find the claim that made that member compliant. We really can't do that in any of the applications. We can certainly do it on a onesie-twosie basis to explain that, but none of the apps do that, and not a lot of customers seem to want to do that. If you have a great burning desire to explore it in a way that's different, let us know, because we're more than open to it. In fact, our new CPA application, which gets layered on top of 2.0, actually explores cost and quality at the same time, right down to the physician level. But we don't go any further than you're compliant or not. And they're definitely not in the cubes. Other questions? Yes, sir.
We do a query on just looking at one provider, like readmission data.
Sure.
So like Mercy or something.
Sure. So we're going to go into, the question is, let's do a query on one provider like Mercy and admissions. So what I would do there is I would go into the cost and use report here, overall admissions, inpatient confinements. First thing I would do is I'm going to stick Mercy up at the top in terms of a filter. So I'm going to come down here and say, here's my inpatient facilities, make them a filter. Then I'm going to filter it just for Mercy. And then I can throw in any measure I want, and it'll be just Mercy's measures. So now the question is, where's Mercy? I hope it's under M. And ME. Okay, Mercy, MER. Okay, here we go, Mercy. Which Mercy are we talking about?
Health system.
Mercy Health Center?
System.
System, okay, Mercy. I don't have a Mercy Health System. I got Mercy Medical Center. Maybe we ought to go at this by affiliation. He's looking for Mercy Health System.
Yeah.
Which cube are you in?
I'm in the facility queue,
Like to
admissions.
see Mercy and all the providers within Mercy that are linked to readmission data.
Yeah, see,
It's not set up that way, is it? No. Oh, but maybe what we could do is go in a different way then. Hold on a second. I think I see where you're going. So you want to see, if I go into provider network assessment and I go into population, Maybe I can do it cost detail using the affiliation table. Because Mercy ought to affiliate downhill, right? No?
Not at the hospital level.
Okay. Oh, okay. So that's the problem. What's that? She found it? Okay, we'll show it. Oh, you can't. I'm sorry. Let's see what it looks like. What is it called?
It's on page 2 and it's Mercy System.
Okay. Oh, so it's Mercy System, not Mercy Health. Okay.
Mercy Health System.
Yep.
Page, second page. The third one.
Yep. Okay, Mercy System. No, she says it's Mercy System. Oh, it's Mercy Health?
Second, Mercy Health System.
Okay.
Mercy Health.
I am on page 2.
Scroll down.
Keep going down.
We're almost there. Almost there, keep going.
Yeah. So
This one?
The three of them.
The 3 of them. Okay. There we go. Okay, so now that we've got those called up, what would you like to know about them? What other dimension should we bring in?
Specific, maybe diagnosis related groupers like DRG
Okay.
1, 2, 3.
Yep, I can add that to a row axis right here.
Associated with them.
Okay. Cost associated with them would be down here. Inpatient services, total standard cost, add to the data area. So what we've got is, we've got pregnancy and childbirth, far and away the biggest one, down at the bottom. Or we can sort it. Actually, no, that's wrong. Diseases of the musculoskeletal is the highest. And here you can see it's major joint replacement or reattachment. That's actually driving it in that particular facility. Other questions? Sure I can. Did you get it? Yeah, you sure are. All you got to do is put service, yep, total standard cost, and you got it. Now, a neat thing to do here is not total standard cost. To be quite honest, the best thing to do here is to take your average cost by DRG and compare it to other facilities. Because the standard cost is going to be the same for all the facilities for the same procedure, so you can actually see if there's differences in there.
Show us how to do
Absolutely.
it, please.
So in this particular case, I'm going to drop it back to here. And what I'm going to do is go over and go down to my measures. We have calculated measures here. And we have standard cost per admission, standard cost per day. So we can pick whatever one we want to put in there. Let's take standard cost per day. I'm going to replace the data with that. And this is just going to be Mercy right now because that's all we have included in there. So there's the standard cost per day for just Mercy. So let's say, for example, I wanted to put another facility in there instead of Mercy, or I wanted to divvy up those 3 Mercies that you guys had there, right? If I want to divvy up those 3 Mercies, one of the things I could do is I could take this and I could actually move that to a column. So now I've got all of my DRGs coming down this way, and then I've got all my hospitals coming across this way. And I'm going to go back in there and I'm going to set the filter across the column to just show the Mercies, the 3 of them. Now I don't know if they're one hospital or they're actually 3 separate facilities. Are they?
Do you show all the providers within the Mercy as well?
We'll be able to click the plus sign after we select those. Yep. So now we're going to go back and do exactly what we did before. Get into the M's. Get into the MEs. Go down to the second page. find Mercy. And we had Mercy Health Systems for Wisconsin, those three. We'll say okay. And what it's going to do is it's going to take everything up here on the columns, and it's going to drop it into just those three. And then if we have a plus sign, that means there's additional information below that in terms of the affiliations. And it may be if they're the same entity, you're all going to see all the dollars under one. I don't know if those three things are the same entity or not. And so now we have M, so we can drill into M. Okay, while it's thinking, are there any other questions that folks want to ask or answer? Because we're about to wrap it up and leave the remaining half hour for just questions if folks want to stay around, or you're kind of free to go.
Is it possible to compare against all Brown County providers?
Absolutely.
Or sorry, whatever county it's in.
Absolutely, you can do that. And see, M has just come up to M and ME, so they're all MEs. And we'd have to click it one more time and let it run. But yeah,
So that would be under geography.
that is correct. You do geography.
So before everyone makes a vote for it, I want to thank everyone for coming. As Paul said, we can stay till 4. Happy to help with any specific questions. I sent a survey link to you all. If you could please take a couple minutes and give us your feedback on our training. We want to make it as best we can to meet everyone's needs. So thank you again for coming.
Great job.
Thank you.
You're welcome.